Hi everyone. My name is Dana, if you don't know me. I'm a PGY1 pharmacy resident, and today I'm going to be presenting on why the world is going ape over monkeypox virus and what you need to know. So as for disclosures, I have none. And as for acknowledgements, I just wanted to thank Katie for helping me with this presentation and looking it over and making sure everything was sound. So today we have 4 objectives that I want to go over. So those include defining monkeypox, its origin, manifestation, and transmission, recognizing the history of monkeypox and its current global, national, and statewide presence, identifying and obtaining a general understanding of the treatment and disease state management, and describing the safety precautions to prevent the further spread of monkeypox. So you're seeing monkeypox in the news, it's all over your feed, what's going on. And so it's important as clinicians for us to really hold our fingers on the pulse of what's going on in the world. But the only way that we can do that is really by understanding the history and understanding if monkeypox has ever happened before. Is this the first time that we're seeing it? And so the answer to that question is no. So previous to this timeline in 1958, there was actually a shipment of cynomolgus monkeys from Singapore to Denmark to be studied in a Danish lab where they fell ill. And this was the first we're ever really seeing the monkeypox virus. And it wasn't until 12 years later, in 1970, that a human actually ends up getting monkeypox virus. And so we see it in a 9-month-old girl in the Democratic Republic of the Congo. So throughout time, we have sporadic cases. You can see on this timeline in the West Africa, tropical rainforests of the Congo Basin, Liberia, Cameroon. And it really wasn't until 2003 that monkeypox came to the United States. So the story of how this happened was there was actually a shipment of around 800 mammals and rodents shipped from Ghana to Texas. In Texas, there was an Illinois animal vendor who purchased these rodents and then brought them to 2 pet shops in northern Wisconsin. So those rodents came in contact with pet prairie dogs, which is a common pet to have in that part of the country. Those pet prairie dogs came in contact with humans. It then spread across 5 states and caused around 47 cases. So this is the first we're seeing an outbreak in the United States. And then the most recent epidemic was in the Central African Republic in October of 2016, and we're seeing around 27 cases in 2016. So fast forwarding up to now in the United States, 2021 to 2022, on this slide, I have a couple landmark dates, and they're really marking the first cases that we're seeing recently. And in common with all these, you can see that the cases are caused due to someone having international travel. So 2 travelers coming back from Nigeria. And although we can't point fingers and say that it's definitely due to travel, these are what we're seeing in common among the cases that are being reported in this recent outbreak. So now, as for global projections, we're seeing as of August 19th, 2022, we have total cases of 41,358. And these orange dots are representing locations that have not historically reported monkeypox, with the blue dots representing places that have historically reported monkeypox. And those only account for about 7 cases. So the orange dots, as you can see, are quite large. We have 40,971 in those other places. We have a very large dot on the United States, as well as a bunch of smaller ones on the European nations. However, if they were to accumulate into one large dot, it would be covering almost all of Europe. So as to further that point, I have this global distribution graphic for you to see. So you can see that the red line is representing the European Union. So we have a very steep slope showing us that there is an incline on cases starting in May and increasing till now. And there's a steep slope on all of these nations. So blue being the United Kingdom, light blue being Canada, and yellow being the United States, as well as purple being Brazil. So they're all on the incline during this outbreak. So now I wanted to talk a little bit about the global demographics of what we're seeing, monkeypox, the type of people that are getting it. So this was a case study that included around 528 infections diagnosed between April 27th and June 24th, 2022 at 43 sites. And so the characteristics that we're seeing is that the median age is around 38, as well as almost entirely in the male population. It's also almost entirely in the homosexual population. So monkeypox is currently disproportionately affecting the LGBTQ+ community. And then the last part at the very bottom is foreign travel in the month before the diagnosis. So the content of travel, as you can see in Europe, furthering that point previously, is that around 90% of people have traveled to Europe and then reported a case of having monkeypox. So this is a question. Feel free to unmute yourself or write it in the chat. Which states currently have greater than 500 cases of monkeypox? Correct. So F, all of the above. So now we're narrowing our scope a little bit from global to national. You can see as of 8/16/2022, we have a total of 12,689 cases, with the highest amount of cases in our most densely populated states. So New York, Florida, Texas, California. And then at this time, Wyoming was doing really well and had 0 cases, but the shade of blue demonstrates the number of cases. And of course, the most densely populated, as mentioned before, have the most cases. So now I want to narrow our scope even a little bit more. So now we're going to talk about New York. And so I broke it down between Manhattan and Suffolk. So for Manhattan, there's around 1,104 cases, and this is out of the 5 boroughs, so including Queens, Bronx, Brooklyn, Staten Island, and Manhattan. And Manhattan makes up about 45% of those cases, where in Suffolk County, we had around 39 cases at this time, out of the 192 cases reported in the capital, central, metropolitan, and western regions of New York. So Suffolk makes up about 20% of those cases. So now I want to go into the definition of monkeypox. So monkeypox is defined by the Centers for Disease Control as a rare disease caused by infection with the monkeypox virus. It results in mild symptoms, and the mortality rate is from 0 to 11%, with increased mortality towards 10% in the pediatric population. So monkeypox falls under an umbrella term called poxvirus, and a poxvirus is a large double-stranded DNA virus that replicates exclusively in the cytoplasm. So poxviruses come in a variety of types, but the one that we're specifically talking about is the orthopox virus. So monkeypox, alongside a couple of the other notable members mentioned on this slide, are orthopox viruses. So now I just kind of want to differentiate between the different kinds of viruses that can be confused. So between monkeypox, chickenpox, and smallpox. So starting off with the fact that monkeypox and smallpox come from the same orthopox family, whereas chickenpox comes from the varicella zoster virus. I also want to point out that the telltale sign that we're seeing in monkeypox is the swollen lymph nodes. So that's in comparison to chickenpox and smallpox, where you don't see those swollen lymph nodes. And then lastly, the difference lies in how long the illness lasts. So monkeypox has been seen to go for 2 to 4 weeks, whereas chickenpox is just around a week, and then smallpox can go up to 5 weeks. So now I want to talk a little bit about the life cycle for the orthopox virus. So starting off with that first circle, we have the virus, which is going to attach and enter into the cell. It then begins to uncoat. We have early gene replication, early gene expression, and gene replication. Then we move on down to the virus factory. So we have large crescent-shaped masses that are going to surround the virion, which is ovular shaped. Once it matures, it turns into a dumbbell shaped. It's going to then travel to the Golgi body where it gets its lipid bilayer and becomes a wrapped virion, and then it gets released from the cell as an enveloped virion. And just to remind you that this all happens in the cytoplasm, not in the nucleus. So you might be wondering how such a large virion that doesn't replicate in the nucleus, how is it going to evade our host defense system? And it does this in two ways. So it does this through intracellular proteins as well as extracellular proteins. And so the point for the intracellular proteins is they're broken down between biotransducers and viral stealth, and they essentially downregulate our immune recognition molecules so that the virus can sneak in. As for the extracellular proteins, we have viroreceptors and virokines, and those mimic the host cytokines and subvert the host responses. So it's essentially a game of hide and seek for the virus to get in, mimic what's already there, and sneak right in to cause the infection. So monkeypox comes in two types. So in the blue, we have the endemic Congo Basin Central African clade. In the more pinkish peach color, it's an endemic West African clade. And in the red spots all over the globe, those are actually coming from the West African clade. And that one's known to be less virulent and with a lower mortality rate. So for as the natural reservoir, which is essentially where the virus accumulates and persists, we're not entirely sure. So the host does remain elusive. However, we did see it in those cynomolgus monkeys mentioned before, as well as in rope squirrels, Gambian pouch rats, and other rodent species are vulnerable. So as for transmission, it's important to note on this slide that any person, irrespective of gender identity, sexual orientation, or age, can acquire and spread monkeypox. Although it's affecting a specific group right now, anyone can get it. And the four main ways that it can be transmitted is firstly through skin-to-skin contact. So this can be through direct contact with the rashes or the scabs of an infected person. It can be from the respiratory droplets or the secretions from hugging, massaging, or prolonged face-to-face contact. It can also be spread through fabrics and fomites, so touching the porous fabrics of someone who has monkeypox, their towels, their bedding. And one study actually found a live virus 15 days after a patient's home was left unoccupied, so it can last pretty long on these surfaces. The third way is vertical transmission, so a pregnant person can spread live virus to their fetus through the placenta. And then less commonly, but it does still happen, it can be transmitted through animals, whether it's through an animal bite or through eating the meat of an infected animal. So as for the risk factors, it's for people who live with or have close contact with someone who has monkeypox, as well as health workers. They should follow infection prevention to protect themselves when they're caring for patients that may have monkeypox. And as of course, always the susceptible population of newborn infants, young children, and people with underlying immune deficiencies may be at risk for more serious symptoms. So now I kind of want to go through a flow of how it first gets transmitted to how it clinically manifests. So starting on the top, we have the human to human transmission, and on the left-hand side, we have the animal to human transmission. And this enters into the lymph nodes and becomes primary viremia all within the incubation stage. So the incubation stage is around 3 to 17 days, and this is not contagious. Once it moves on to secondary viremia, so it's spreading to distal lymph nodes, it then enters the prodromal stage, which is around 5 days. And we believe that this stage is possibly contagious, but it's not until it clinically manifests within the tertiary organs and the skin that a patient is fully contagious. So true or false, monkeypox causes a rash that presents as thick and leathery skin. Correct, so false. So for the rash that's seen with monkeypox, it can be shown with pimples or blisters that are painful or itchy. They can be on the genitals, the hands, the feet, the chest. But some of the other symptoms that you might see are muscle aches, the swollen lymph nodes, as mentioned before, backache, chills, respiratory symptoms that mimic the flu. And the complications of not treating monkeypox can result in scarring, cellulitis, or dehydration. So this is what the rash looks like. If someone has flu-like symptoms, they will develop a rash 1 to 4 days later. And once a patient has this rash, they are contagious. And it's not until all the scabs have fallen off and a fresh layer of skin has formed that a patient is considered no longer contagious. So this is the stages and durations of what happens with the rash. So it starts off as a macule, which is flat. It lasts 1 to 2 days. It then becomes raised, lasting 1 to 2 days. It becomes vesicular, so filled with fluid for 1 to 2 days. It then becomes pustular for around a week, and then it forms a scab for 7 to 14 days. So although the diagnosis of monkeypox can be suspected in patients with a rash, as well as having the risk factors for the infection, the best way to confirm a diagnosis is one or both of these ways listed on the slides. So the first one being a tissue sample, which would essentially be rubbing vigorously on one of the lesions. It doesn't have to be entirely uprooted, just rubbing the lesions and then placing the sample to be sent to the lab for polymerase chain reaction testing. The second way would be a blood sample to check for the detectable levels of anti-orthopox virus, IgM antibodies. So many people have a mild self-limiting disease course and they don't require pharmacologic therapy. So some of the options that we can provide them for supportive care would be to stay hydrated, use an oatmeal bath for the skin lesions. You can have ice chips for the oral lesions. You can do a sitz bath, or you can use DocuSate if proctitis is present. And these are the treatment considerations for monkeypox when considering to give pharmacologic therapy. So firstly, therapy would be given to someone with a severe disease, including sepsis, encephalitis, or hemorrhagic diseases, as well as those at high risk for severe disease. So that's our immunocompromised population with HIV or leukemia, our pediatric populations, our people with exfoliative skin conditions that have psoriasis or atopic dermatitis. And lastly, infection in atypical sites would be someone who would receive pharmacologic treatment. So those would be atypical sites, including mouth, eyes, or genital area. So currently there's no treatment approved for monkeypox, but we do have interim clinical guidance for treatment. So starting off, our first line therapy is going to be tecovirimat, brincidofovir, cidofovir, and vaccinia immunoglobulin intravenous. So first I'm going to talk about tecovirimat. So in the red box, I have the dosing for your convenience. It comes in an oral and an IV form. Currently, it's off-label for severe monkeypox. You administer it 30 minutes after a full meal high in fat because it was found that fat actually increased the AUC by 39%. It's contraindicated in a creatinine clearance less than 30. And currently is first line in pregnant patients, although pregnant patients are not currently in the pharmacokinetic studies. It's really their best option right now. And tecovirimat is overall very well tolerated. The main adverse effects that were noted was pain at the injection site for the IV, as well as headache for the oral. So this is the mechanism of action for tecovirimat. So flashing back to what I spoke about before with the orthopox virus, at the top left, we have the attachment and entry. We have the early gene recognition and gene replication entering into the virus factory, becoming an immature virion. And that's where tecovirimat works. So tecovirimat inhibits a protein called VP37, and this prevents the immature virion from becoming an envelope virion, and therefore hindering the spread of the virus out of the cell. So it gets stopped right before becoming enveloped. So this is the TPOXX procedure at Stony Brook right now. There's essentially 3 phases as to what's going to happen when a patient with monkeypox comes in that is going to get TPOXX. So the first part is prescribing, and this is where the prescriber fills out a packet. And in the packet is a consent, intake, and outcome form. And then they're going to enter their order into Cerner as a TNF. Currently, it's going to go in as non-form. The next step is dispensing. So a pharmacist verifies, fills out the RX label, and prepares the capsules. So the capsules are 200 milligrams each. So when preparing the capsules, a total regimen would be 3 capsules every 12 hours for 14 days, which would be a total of 84 capsules. So it's important to fill out the inventory tracker, and then the med is delivered to the caregiver. And then the last part of it is the returning forms that are necessary to be given back to the pharmacy. So that would be an intake form and a copy of the consent form. And those are currently in a TPOXX folder on Janine's door. So then we're going to move on to our next medication, which is brincidofovir. I do have the dosing at the top for your reference. Additionally, what I want to point out about brincidofovir mostly is that it does have a very specific adverse effect of hepatotoxicity. So it's super important to be monitoring our ALT and ASTs, as well as in order to initiate a pregnancy test for female is necessary because it has been shown to be teratogenic. Next, for cidofovir. So cidofovir remains a reference compound against pox viruses and holds potential for the therapy for orthopox virus. The reason that it's not first line is due to its nephrotoxicity. So in the third bullet, we have the dosing, which is now being given with probenecid. So probenecid is nephroprotectant. So the nephrotoxicity is due to the relatively slow secretion of cidofovir into the renal tubules. And so what probenecid does is it inhibits the transporter that causes the tubular uptake of cidofovir from the blood, therefore protecting the kidneys. And so experts are saying right now that they recommend cidofovir when TPOXX is contraindicated, as well as the potential of using cidofovir in combination with TPOXX in severe cases. So what you may have noticed is cidofovir and brincidofovir sound very similar, and they do have very similar mechanism of action. So for brincidofovir, they have a lipid side chain, and that's what allows them to enter the cell quickly through passive diffusion, which sets them apart from cidofovir, which is a charged molecule that slowly enters the cell. But once both of them are within the cell, they act the same and prevent viral replication. And then lastly, for vaccinia immunoglobulin intravenous, this is essentially containing antibodies from the blood of people who are immunized with the smallpox vaccine. And it's being considered for patients with severe monkeypox, as well as prophylaxis, and those that are immunodeficient and cannot receive the smallpox vaccine. I also have the dosing on this slide for you. And then for the adverse effects, we've been seeing anaphylaxis, pulmonary edema, as well as thrombotic events. And then lastly, we have trifluridine eye drops, which is being used to treat orthopox virus associated corneal lesions. And it has found to hasten the symptom resolution and prevent long-term damage and scarring. So I created this chart to make it easier when it comes to narrowing down our selections when we're presented with a certain type of patient. So for example, in hepatic insufficiency, as I mentioned before, you can go with certain options except brincidofovir, which has shown hepatotoxicity. For our pregnant patients, right now our first choice would be TPOXX. For our NPO patients, we can go with most of the options except brincidofovir, which currently only comes in tablet and suspension form. And then for use in pediatrics, the only ones that we can be using so far are TPOXX and brincidofovir, and we're not quite sure with VI-GIV. So for patient counseling on protection from monkeypox, there's 3 things I want to touch upon. Firstly, being avoiding that close skin-to-skin contact with people who have a rash that looks like monkeypox. So you don't want to be anywhere near those lesions, no hugging or kissing or cuddling, as well as avoiding contact with the objects and materials that a person with monkeypox has used. So those towels and sheets and cups and bedding. And then lastly, as with any virus, it's recommended to wash your hands often, where soap and water is preferred. So another prophylactic measure that we're taking is vaccination. So the CDC is recommending vaccination for people who have had contact with someone with monkeypox. They've had sexual partners in the past 2 weeks with someone who had monkeypox, as well as laboratory workers who are performing the testing and handling of the orthopox virus. So the current vaccines that we have available are ACAM 2000 and Jynneos. So firstly, for ACAM 2000, this is a live replicating vaccinia virus. It's a virus vaccine. It's administered as a single dose by the percutaneous route. And what you're seeing on the right-hand side is essentially a picture of something called take, or a major cutaneous reaction. And this is what happens in a successful inoculation. So essentially, you're simulating what would happen if the person were to get the virus. So they're going to start off by forming a pustule, a papule, it becomes vesicular, and then it turns into a scab and falls off. So we're simulating exactly what would happen if the person were to get the virus. And it takes 4 weeks for max immune protection, and it's also high risk for adverse effects, as well as being contraindicated in the immunocompromised. So the other vaccine is Jynneos, and this one is different in the fact that it doesn't cause this take or major cutaneous reaction. It is an attenuated live virus vaccine with a standard regimen of 2.5 ml subcutaneous doses 28 days apart, as well as an alternative regimen, which is 2.1 ml intradermal doses with similar immunogenicity. The difference with this one is it has peak immunity 14 days after the second dose, although the duration of immunity after the 2 doses is still unknown. So right now, pharmacists are not able to administer monkeypox vaccines, but it is currently being advocated for, as well as when I became a vaccinator, I was only taught how to do the intramuscular and the subcutaneous route, and we were never taught how to do the intradermal route. So I wanted to include a video explaining how to give this vaccine intradermally.
How to administer a vaccine intradermally. Locate and clean a site for injection in the inner or volar surface of the forearm. While pulling the skin taut, position the needle with the bevel facing up and insert the needle at a 5 to 15 degree angle into the dermis. Slowly inject 0.1 milliliters intradermally. This should produce a noticeable pale elevation of the skin or wheal. Observe patients for 15 minutes after vaccination, or 30 minutes if they have a history of anaphylaxis to gentamicin, ciprofloxacin, chicken, or egg protein. Learn more at cdc.gov/monkeypox.
So now I have another question. So which person is a candidate for PEP++? So A, Sarah kissed her boyfriend yesterday who tested positive for monkeypox. B, Jack is a lab worker handling monkeypox cultures. C, Larry thinks he may have been exposed at a party he attended with a sick guest. D, Gail touched the used towels of her sick roommate who came down with monkeypox 2 days ago. And E, none of the above. Okay, so the correct answer is actually C, and I'm going to go over it right now. So for monkeypox vaccine, they're currently doing 3 main ways of giving the vaccine. So we have pre-exposure prophylaxis, post-exposure prophylaxis, and then we have post-exposure prophylaxis plus. So PrEP is essentially for lab and healthcare workers, and they can get vaccinated with either ACAM 2000 or Jynneos. As for post-exposure prophylaxis, this is for the patients that have been exposed to monkeypox virus within the past 4 days, and it can reduce the symptoms of the disease, but it may not prevent the disease fully. However, the quicker they can get the vaccine, the more effective the protection and the better. And then PEP++ is essentially for the individuals that have a presumed exposure to someone. So they think they might have been exposed to someone with monkeypox. So as for isolation and prevention recommendations, I'm starting off with the respiratory symptoms. If a patient is experiencing those, it's best to remain home away from people and animals, avoiding public transportation, and wearing a well-fitted mask when they go out. For rashes, it's important to cover the lesions with clothing, gloves, and bandages. And once again, full healing of the rash means formation of a fresh layer of skin. And then lastly, until full resolution, it's important to isolate, avoid crowds, and as always, wash hands often. So this is the CDC recommendation in the order that you should be disinfecting the home of someone who has had monkeypox and is symptomatic. So firstly, starting off with just general soiled waste containment should be collected in a sealed bag. It's important for laundry when you're gathering it. You don't want to shake it because it can release the airborne particles into the air and further spread it. For hard surfaces and household items, you want to use a disinfectant. For upholstered furniture and carpet and flooring, you're not going to want to dust, sweep, or vacuum or use any of those methods that can redisperse the molecules into the air. So you're going to want to use wet wipes and things like that. And then for waste disposal, it's essentially just collecting all of it and sealing it in a bag. As for infection control for healthcare professionals, there's two things I want to touch upon. The first being patient placement and precaution. So these patients will be isolated in a single room with a dedicated bathroom. Their transportation is limited, and when they do move around, they'll be wearing a well-fitted mask and their lesions will be covered. And secondly, for healthcare professionals, to wear PPE when entering those rooms. So firstly, the gowns, the gloves, the eyewear, and then the NIOSH approved particulate respirator are all important when entering. So these are some of the questions that we still don't know the answer to, but are in the works. So which treatment works the absolute best for monkeypox? What is the ultimate catalyst for this monkeypox outbreak? We do know that they have that common thread of traveling, but we're not quite sure if we can point fingers to one specific event. Can the virus be spread when someone has no symptoms? Do people with immunosuppression have more monkeypox virus present in body fluids? And lastly, is monkeypox present in the body fluids, including urine, feces, and semen? So just to give an overall summary, monkeypox is an orthopox virus and it manifests in humans as a rash that lasts 2 to 4 weeks. This is not the first time we've ever seen monkeypox. It has been in the United States before. However, it is super important that right now, since we're seeing it, we should know about the cases that are on the rise globally, nationally, and in New York. Although most cases of monkeypox are self-limiting and require the supportive care only, there is interim guidance regarding the medication options. And then lastly, by following CDC guidance, we can protect ourselves and others and prevent the further spread of monkeypox. Thank you. Any questions?